Okay, we're going to go ahead and start now. Today we're going to take a look at the axial skeleton. We've looked at the skull and we've looked at the appendicular, we've looked at the axial skeleton. We're going to look at the appendicular skeleton today. Are there any questions on any of this or on anything in general? Okay, and if that's the case, then I'm going to go ahead and open up okay, hang on one second. Okay. Oh, lecture test or the lab tests? Because I left well, I'll answer your email on Outlook and get back to you. The lecture test should be open until the 24th. I think I set it for that. 23rd or 24th. And no, the next lab test will not open up on the 28th because next week we're going to cover the joints and articulations, and that'll lead us into spring break. And then we'll have our lab test on bones and joints and articulations. It'll open up when we come back from spring break. So, and I'll leave it open. Given the realities of timing, I'll open it up on that first day back from break, and I'll leave it open for a week. So, okay, good question. Now let's see if I get this to work right now. Here we go. Okay, now we're looking at marked. Yeah. Okay, we're looking at the appendicular skeleton today. Appendicular skeleton is made up of the bones of the arms and the legs, the hands and the feet, the fingers and toes. The good news is that everything on the left side of the body is matched by the same structure on the right-hand side. The fingers and toes all share the same name. They're all called phalanges. I'll show you that here in a minute. And they, so this isn't that, excuse me. This is not a very challenging, thank goodness, section of bones to go through. I mean, there's a lot to look at, but there's not a lot of different names you have to remember. The first bone we're looking at right here is the clavicle. Clavicle is our collarbone. You can feel your clavicle. You can put your hand just on either side of your neck or just come off your shoulder towards the middle of your neck, and you'll feel this bone sticking out there, bulging out. That's your clavicle. Now your clavicle will articulate in two areas. It'll articulate on your sternum. In fact, you can see it here. It has what we call an acromial end and a sternal end. Let me get this out of the way for us. And the sternal end, the medial side, is going to articulate right there. There's the sternum, you can see. And let's see. There we go. Of course, now I don't want to do that, so let's try it again. Oh. Technology is wonderful when it works. Okay, now here we see, this is the clavicle, this bone right here. We have one on each side. And it articulates in two places. It articulates against the sternum right here. That's the sternal end. Right below the jugular notch. The jugular notch is this notch here in the middle. We saw that last time, jugular notch. And the sternal end is articulating right there. That is this flat end. I mean, this rounded edge here is going to articulate there. The other end of the clavicle is flattened. The other end of the clavicle is flattened. You can see it's flat here as it goes around. You can, you can see how flat the end of it is. That is the acromial end. The acromion is another process on our shoulder blade. That flat end of the sternum of the clavicle will articulate with. Remember, articulations occur where two bones come together and move. And so what you're seeing right here is this flat end. This is the flat end. This is the acromial end, because the structure it articulates against on the scapula, on the scapula, is called the acromion. And between the clavicle and the scapula and the shoulder and the humerus forms our shoulder joint. Let's clear that and get this moving here. Okay, now. And you can see here where the sternal ends articulate on the sternum, directly below the jugular notch, a little depression in the manubrium. And then the flat ends, the acromial ends, are going to articulate on the flat structure on the scapula called the acromion. And that's what we're looking at here. Here's our scapula. This is our shoulder blade. You can reach around over your shoulder and feel a ridge over. If you take your right arm and put it on top of your left shoulder and stick your hand on your back, you'll feel a ridge sticking up. When you do that, you are brushing up against this ridge right here. That ridge is called the spine of the scapula. And you can feel that. That's our shoulder blade. You can feel this ridge sticking up here. You put your right hand over your left shoulder or your left hand over your right shoulder, you're going to feel the ridge on either side. That is the spine of our scapula that you can feel through your skin. Now, these structures that we see here, there's our scapula. Now, this big flat area that we see, first of all, if we look at a model of this, we would see it's called the infraspinous fossa. The infraspinous fossa, infra means below. Spinous means ridgeline, in this case. Fossa means flat area. So what we're looking at here, we're looking at the infraspinous fossa is this flat area that's below the spine. Here's the spine right here. Infra means below, below. Spine refers to the spine here. Fossa means flat area. So the infraspinous fossa is this flat area below the spine. Now, you can't really reach it very well, and you're not going to feel it because it's covered with muscles. But there's this big flat area called the infraspinous fossa, the flat area below the spine. Now, the next thing you should see is what's known as the glenoid cavity or fossa cavity. The glenoid cavity, that is our socket. That's our shoulder socket. It's not much of a socket. It's pretty flat. In fact, it doesn't have, you would be hard pressed to say it's a socket. Sometimes we just call it the glenoid cavity because it's just a flat area. But that's where your humerus the long bone, the large bone of your upper arm, the only bone of your upper arm, will articulate here. So our humerus fits into the glenoid cavity right there. There's the spine of our scapula, the spine that we can feel through our skin. Now, we have two processes that stick out from our scapula. We have what's known as the coracoid process, and we have the acromion process. You can tell them apart because the acromion is flat. That's where the clavicle, the shoulder, the collarbone articulates. The acromial end of the clavicle articulates against the acromion process, and it forms sort of a hinge there. Because now we have the scapula in the back and the clavicle in the front, and they articulate at the acromion process, and they're sort of hinged, if you will, because our shoulder has so great a flexibility, we can almost rotate our arm a perfect 360 degrees around, almost, because of that flexibility. We have a lot of give at the shoulder. A lot of it is because of the attachment of the clavicle to the acromion process. Now here we have the medial border of the scapula. The medial border is the side closest to the midline of the body. It is called the vertebral border because it butts up right above the vertebrae. So this long, flat, curved border here is the medial border. It's on the inside of the scapula. So you can look at a scapula and tell which side is which, because there's a border that's coming out below the glenoid cavity. That's not the vertebral border. This border is called the axillary border. We know we can trace it. We can trace it from the glenoid cavity. And so we have our glenoid cavity right here, and this is the axillary border here. So the vertebral border is the one on the opposite side. It's the one closest to the vertebrae. Because remember, here's how you can tell it apart. Take your scapula and place it on your back. Two things have to work for that to feel comfortable. First of all, the spine has to be out. The spine has to be on the outside of the scapula. Second of all, the glenoid cavity also has to be on the outside, facing out towards the armpits. So that you can tell immediately if it's a left or a right. Not that I don't really care, but now. So there's our vertebral border. There's our axillary border. Axillary is the name for the armpit region, the axilla. So the axillary border is the border closest to the armpit. It comes right off of the glenoid cavity, the glenoid fossa. The pointy end, that's a technical term. The pointy end of the scapula is called the inferior angle. And if you have inferior, you got to have superior. And in this case, there's our superior angle right there. Because anytime you have an interior or an inferior, you're going to have a superior. If you have an anterior, you're going to have a posterior. So we have a inferior angle and a superior angle there. Remember, the spine is only on the outside surface of the scapula. And there is our superior border. It's on the area of the spine itself. Okay, there's our glenoid cavity right there. Glenoid cavity, glenoid fossa. We have, that's where the humerus will articulate against. Note the junction of the acromion and the clavicle. The acromion is here. This is the acromion process here. This is the clavicle here. They form this joint right there that acts a lot like a hinge for us. Okay, now, there's the acromion, highlighted in green. You can see how it comes together. Now, it is not just two bones rubbing together. It is surrounded by connective tissue. It's surrounded by ligaments. It's surrounded by tendons. It's covered with muscle. And so we have this great range of flexibility right there at the shoulder, thanks to this junction of these two bones. Now, the coracoid process sort of comes off the glenoid cavity. If the acromion, let me go back one. If the acromion's coming off the spine, the coracoid process is coming off of the glenoid cavity, the sort of bulges up here. What's it there for? It's there for muscles to attach to. It's there to be covered by ligaments and tendons. That's what it's there for. That's what it does. It's a point of attachment. That's about the best I can say for it. It's not as exciting as the acromion process, but it's there for attaching muscles and ligaments and tendons, because this whole area is covered by muscles and ligaments and tendons. So it can have its flexibility. Okay, a couple other terms here. We saw the infraspinous fossa. You know, the infraspinous fossa is this region down here. This is the infraspinous fossa, you know, below the spine. Well, now we have this area up here highlighted in green. That is the supraspinous fossa. And the supraspinous fossa is the flat area above the spine. Now, when we get into muscles in the next unit, you're going to see there are muscles that are found on the supraspinous fossa and in the infraspinous fossa. So this is an area covered by muscles, both supraspinous and the infraspinous. Another view of our scapula. There's our glenoid cavity, looking at it straight down, looking straight down on the spine. There's the acromion. Tucked away over here is the coracoid process. Here is the axillary border. We know it's that because it's closest to the glenoid cavity. That means this is the vertebral border over here. There's our spine, the infraspinous fossa, the inferior, that's the inferior angle, the supraspinous notch, the supraspinous fossa, and they're divided by the spine. It's at supra above the spine. There's the vertebral or medial border. The lateral border, the axillary border, comes off the glenoid cavity. This side is the side closest to the vertebrae or near the midline. It's the medial border. Here we look at the underside. We're looking at the underside of the scapula. Now we have another fossa. People tend to get this mixed up a lot, that this is what's known as the subscapular fossa. We're looking at the underside surface. This is the surface that rests up against the ribs. The subscapular fossa is the flat area underneath the scapula. Sub, meaning under, subscapular fossa. Notice that there is no spine. There's no spine anywhere along here. No spine sticking out, no spine. We have just one big flat area and it's called the subscapular fossa. Lots of people, I shouldn't say lots, but some people will get this and the infraspinous fossa mixed up. The subscapular fossa doesn't have a spine. The infraspinous fossa does. One's on the top surface, one's on the bottom surface. If you don't see a spine, it's the subscapular. If you do see a spine, it's the infraspinous fossa. Okay, now there's our notch again. Superior angle, inferior angle, axillary border, because there's the glenoid cavity right there. There's the vertebral border there. There's the coracoid process, because it's coming off the glenoid cavity, and that makes that over here the acromion process. And of course, there's the glenoid cavity again. Superior border. Okay, one more shot at our scapula. Here we're looking at the subscapular fossa. We're looking at the underside. You know, there is no spine anywhere along in here. This is one big flat area right here. So there's no spine. This is the subscapular fossa. The notch again, superior angle, inferior angle, axillary border, because it's right up, butted up against the glenoid cavity, makes this the vertebral border down here. There's the coracoid. That means the flat one has got to be the acromion right there. There's the glenoid cavity, because remember the coracoid comes off of the glenoid cavity. Okay. So a lot of key words there about that. You know, you should be able to look at the scapula and be able to tell me the three big fossas, the supraspinous fossa, the infraspinous fossa, and the subscapular fossa without getting them mixed up. You should know the glenoid cavity, the acromion, and the coracoid processes, if nothing else. So now this is the humerus. This is the large bone of our upper arm. It has, this is the first place we're going to see epicondyles. We talked about condyles on the skull, and I said they are a process that essentially goes up and down. The epicondyles go from side to side. You're going to see epicondyles here on the humerus. Now, the humerus is the third bone that comes together to give us our shoulder. Now, this bulge on the side of the end of the humerus is called the medial epicondyle. Now, how do we know it's medial? Well, it says it's medial, so that should be enough. Well, the thing to look at these bones with, and this applies to both the arms and the legs, this is called the head of the humerus. The head of the humerus, the head of the femur, any bone that has a head on it, the head is always going to be going to the medial side, always. So the head's always on the medial side. That means anything lined up with the head is also on the medial side. So the medial epicondyle is this bulge here that's on the same side as the head. And so our first landmark on the humerus is going to be the medial epicondyle right there. This bulge out that lines up with the head. We know it's got to be the medial because it's lined up with the head of the humerus. Now, if we have a medial, that means we got to have a lateral. And this bulge down here on the opposite side is called the lateral down here. Okay, medial epicondyle, lateral epicondyle. Always away from the It's always on the opposite side of the head of the bone. It's always on the opposite side of the medial epicondyle. Medial and lateral. Medial points towards the midline, lateral points away. Now, and while these seem like tedious exercises here, these actually have real practical applications in healthcare, because particularly if you're going into radiology, or depending on what you're working in any kind of healthcare, physical therapy or nursing or whatever, knowing the location of our bones and what they do is essential. So this is the first chance you're going to get to learn these. We might as well just, because I know it can be tedious. So anyway, let's go on. Medial epicondyle, lateral epicondyle. We have a bone called the trochlea. We have a bone called the trochlea. It looks like a big round dish there. And directly below that, we have another bone called the capitulum. Now, the capitulum and the trochlea are what allow us to flex our arm at the elbow and also rotate our lower arm so that we can open a doorknob, for example, or turn a key, or whatever we have to do when we turn our hand around something. The trochlea and the capitulum. The trochlea is on the medial side. The capitulum is on the lateral side. We have a fossa here right behind the trochlea and capitulum called the coronoid fossa. More on that one later. We have a bulge here called the deltoid tuberosity. Tuberosity is a new word for us. Tuberosity means bulge, where the bone sticks out. Now, in this case, the deltoid tuberosity is the point of attachment of a specific muscle. And the name of the muscle is the deltoid muscle, the big muscle that covers your shoulder. It attaches itself to the humerus here at this bulge called the deltoid tuberosity. Tuberosities are usually where muscles attach anyway. So now we have the deltoid tuberosity. The shoulder muscle attaches itself to the humerus about halfway down your arm. We have two bumps on the head end of the humerus. One's called the lesser tubercle, and the other one's got to be called the greater tubercle. And there's the greater tubercle. There's the head. The lesser tubercle is on the head side. The greater tubercle is on the lateral side, and in between is a groove. Muscles attach at all these positions. These are always the points of attachment for numerous muscles. So there's your greater tubercle. You can see it's on the lateral side. Lateral is away from the midline. So in this case, the lateral surface is going that way, lateral, and medial towards the midline of the body is going this way. So this is the greater tubercle here in green, but then this is the lesser tubercle here that I just highlighted. The lesser tubercle is always going to be on the medial side. We'll have another example when we get into the femur called the greater and lesser trochanters. Greater trochanter will be on the lateral side, and the lesser trochanter will be on the medial side. Okay, now, so there's the greater tubercle. Here is the posterior surface of our humerus. And you can see, again, the head of the humerus is over here. Bring up my annotations again. There we go. The head of the humerus is down here, but again, it's facing towards the midline. Here is our medial epicondyle right here, and our lateral epicondyle there. Let's clear this and I'll show you what I'm talking about. Okay. Posterior view of the humerus. The olecranon fossa. The bone that makes up your elbow is called the olecranon. It's a hinge joint. And when it moves, it moves like a hinge. It pivots over the olecranon into the olecranon fossa. You'll see that in a second here. There's our trochlea. There's our medial epicondyle. There's our lateral epicondyle, and the bone here, there's the lateral epicondyle, and then it doesn't show it, but this is the capitulum here. Here is the head. Again, it's on the medial side, right there. So we have the olecranon. The new word here is olecranon fossa. That's a flat area on the posterior surface of the elbow. Okay. So there's your medial epicondyle from either view. Always look at the head. Look at the direction that the head is on. There's the head. There's the head. They're both on the medial side. The medial epicondyle is on the medial side. It's on the medial side here too. Okay. Now the two large bones in the forearm, one's called the ulna and the other is called the radius. Now these two bones are the most distinctive bones in the body, that they have such unique shapes that you can never get these wrong. Now what we have highlighted here is the radius. The radius has a round head. It looks like a stamp almost, but this round head allows the radius to pivot around the elbow, because you have the ability to take if you were to take your right arm and stick your right arm straight out and then turn it so your thumb is going straight up, and then turn it so your thumb's going straight down, you are pivoting your radius inside your arm, and it's pivoting around the head of the radius here. There's our radius. There's the head right there. The head of the radius is pivoting around the humerus. We have a head, we have a neck. Many bones have a head and a neck. It's what's like a surgical neck where we can see, fractures occur, for example. There's the head. Now, you can't tell from this picture, but this bulge right there is called the radial tuberosity. That's a point of attachment of a very important muscle for us. There is the styloid process, the pointy end on this bone. It attaches, muscles attach to the styloid process here at the wrist so that we can turn our wrist around at the end of the radius. And there is our radius right there, highlighted in red. Now, the rotation of the radius. Watch how this works. Now, you've got the head of the radius showing up. Let me bring in the. Okay. The head of the radius is right here. Here we have the medial epicondyle here. Here is the lateral epicondyle here. Here is the trochlea, and the capitulum. The head of the radius, head rotates around capitulum. The head of the radius rotates around the capitulum, so we can turn our arm. We can rotate it around here, like when we open a door, for example. Okay, so there's our head rotating around the capitulum. There is our, there's the trochlea down here next to the medial epicondyle, but there's the lateral epicondyle there. So the flat end of the radius is rotating around the capitulum. Notice how the radius crosses over its position over the ulna. This is the ulna, the bone below here. If you hold your arm straight out with your thumb sticking up, your thumb is in line with your radius. You can tell exactly what your radius is if you take If you stick your arm straight out in front of you with your thumb sticking up, thumb lines up directly with the radius, and you can trace that back to your elbow. The bone underneath is the ulna. So just knowing where your thumb is, and most of us can find our thumb, you now know where the radius and the ulna are located. But when you take your hand and turn it so that the thumb is pointed down, like we do in the animation here, the radius has come down over top of the ulna. You can even see the styloid process on the radius. And the styloid process lines up with our thumb. Even when we turn our hand over, styloid process still lines up with our thumb because we're rotating around the capitulum back at the back end here. So just knowing where your thumb is tells you where your radius is and tells you where your ulna is. The ulna is this other bone, the bone underneath here. Now, another view of the radius. This shows you a better illustration of not just the styloid process, but the head, the neck, and this bulge here called the radial tuberosity. Radial tuberosity is highlighted here in green. The biceps brachii, the large muscle in the upper part of your forearm on your humerus, attaches itself at the radial tuberosity. When that muscle contracts, you bring your arm back up, you bring your hand back up to you. You hold your hand straight out flat, held your arm flat with your hand extended at the end of your arm. If you bring your hand back and touch your face with it, you're pulling it back by pulling on the radial tuberosity. That little green structure right there is the radial tuberosity. So that is the radius, the head, the neck, the radial tuberosity, the styloid process, and the fact that the head rotates around the capitulum lets us turn our hand to open doors and do things like that. Now, below this, the other bone of the forearm, the other bone of the forearm is the ulna. The ulna is the other distinctive bone in the body. It looks like a socket wrench. This is the ulna right here. Note this distinctive structure here at the head of the ulna. That's called the olecranon process. Olecranon process. You want to feel your olecranon process, take your fingers and rub your hand across the elbow. The olecranon process is your elbow. So that bump there that you feel, that we all fell on when we were kids and skinned our knees and skinned our elbows up. The olecranon process is our elbow. There's the coronoid process there. And here we have the trochlear notch. The trochlear notch is where the olecranon, the ulna, articulates on the trochlea of the humerus. Because that process, that the elbow is going to rotate back and forth around the trochlea. And there's our styloid process there. So the ability, every time you flex your arm, every time you bring your hand up to touch your face, you know, you have your arm straight out and bring your hand back up to touch your face, your elbow is moving. The olecranon process is moving back and forth over the trochlea. And that's what you're feeling, the end of that elbow, the end of the arm, the olecranon process. And then the other styloid process there that terminates down by the wrist. So just by knowing where your thumb is, you know the thumb, you know the radius, you know the ulna, you know the styloid process is down at the thumb end, you know the radius has a radial tuberosity and a neck and a head, and the round head articulates, rotates around the capitulum. The ulna has this olecranon process. It looks like a socket, and that rotates, that moves over the trochlea. It pivots over the trochlea so we can move our arm at the elbow. Okay, so here's our palm. We have 3 sets of bones in the hand. We have the carpals at the wrist, the metacarpals in the hand proper, and we have the phalanges. So the phalanges are the fingers. The phalanges are also the toes. So we've got metacarpals in the middle of the hand, and the carpal bones are the wrist bones. And there are 8 different carpal bones, and because they all look about the same, I don't make you learn them. I don't make you learn the bones of the wrist. I will make you learn the bones of the foot, because these are all very similar in shape and structure. For example, trapezium, trapezoid, scaphoid, capitate. I always wondered why there wasn't a decapitate. Hamate, lunate, triquetral, and the other part of that's the pisiform. So very difficult, a lot of, I would just rather you remember that these are the carpal bones. We have enough to learn already, but those are the carpal bones. Okay, and then those are the metacarpals, and then the phalanges. Now, shifting to the lower portion of the appendicular skeleton, first of all, we see this is what's known as the pelvic girdle. The shoulder was called the pectoral girdle. This is the pelvic girdle. And the pelvic girdle is made up of the sacrum, this bone right here, the sacrum, and the 2 hip bones. So this is the female pelvis. Female pelvis is distinguished from the male pelvis because the angle here is much shallower. This looks like an inverted bowl shape here, whereas in the male pelvis, it looks like an inverted V. So first of all, first bone of the female pelvis, same in the male pelvis, by the way. The largest bone is called the ilium. Ilium is found on each side, large bone, 2 large wings that stick up near the top right here and over here, and that's called the iliac crest. Now you can feel your own iliac crest if you stick your hands down by your side and come down to your pocket, about halfway down your pocket if you have a pocket, and slide your hand back and you'll feel a bump. You'll feel a ridge line there. That ridge line is your iliac crest. That's a good landmark. You find the iliac crest, you know where the pelvis is located on the body. So that is your iliac crest. There's the sacrum. Now the bone directly in front of the sacrum is called the pubic bone. We have a pubic bone on each side. They come together to structure called the pubic symphysis, where we have a pad of cartilage here to function as a shock absorber. Okay. Between the pubic bone and the ilium is the ischium. The ischium makes up half of this cavity and half of this socket in here. Now, the junction of the ilium and the sacrum is called the sacroiliac joint. And the sacroiliac joint and the pubic symphysis function as shock absorbers. The shock of motion, the shock of walking, comes up our legs. It's absorbed, it's transferred from the bones of the leg into this socket here and travels around in the back to the sacroiliac joint. From there, the shock of motion is transferred up the spinal column where these intervertebral discs absorb that motion. In the front, on both sides, the shock of moving is transferred to this pad of cartilage here called the pubic symphysis. So we walk, we talk, we walk, we run, we ride a bicycle, we do things with our legs, and it isn't supposed to hurt because the shock is all getting absorbed either by the intervertebral discs in the spinal column, which probably takes care of the bulk of the shock, or in the front by the pubic symphysis, that pad of cartilage located right here in the middle. There's the pubic symphysis right there. And this sacroiliac joint is the connection between the sacrum and the ilium to transfer shock from here to here. Now this big opening, it's a foramen. It's called the obturator foramen. We have to have a way to send blood vessels and nerves down and back into the lower legs. And so they pass through on both sides through the obturator foramen, arteries and nerves going down and veins and other nerves coming back up on both sides. There's the lumbar vertebrae up here. Now this opening here, this socket is called the acetabulum. It's a much deeper socket, a much larger socket than we had with the glenoid cavity in the shoulder. The femur is much bigger than the humerus is. It's much larger. The head of the femur is much more pronounced. So we need to have a bigger socket for it here, and that's what the acetabulum does. But we also discover that we don't have the flexibility at this socket that we had or that we have at the glenoid cavity. We can't rotate our leg as much as we can rotate our arm. We don't have the extreme flexibility. This angle here, this is called the pubic arch. The shape of the pubic arch determines, is an indicator if it's male, or it doesn't determine if it's male or female. It's an indicator if it's a male or a female pelvis. The pubic arch in a female pelvis is very broad and wide to allow, there's a larger gap here to allow for a passage of the baby through the birth canal and at childbirth. The male pubic arch is much narrower. It's shaped more like an inverted V. Okay. Now, here we go again, the female pelvis. There's the coccyx. This is what's known as the true pelvis. That is the area, the width from edge to edge of the iliums. And we have also what's known as the false pelvis, where we go from iliac crest to iliac crest. It's also, it's larger than the true pelvis, but the true pelvis is the space between edge to edge within that area there. This is the false pelvis up here. So now, the pelvic brim is the edge of the pelvis area. Here it incorporates the pubic bone, the iliac bone, and the ischium, the ilium, and the pubis together to give us that brim. Now, pubic arch again. Okay, now, looking at it from the posterior side, we see the coccyx and the sacrum. Here's our ilium. Here is our ischium. The pink bone is the pubis. There's the pubic arch right there. There's the coccyx. The iliac crest up at the top. Ischial spine. Now, close up on what we call the coxal bone, we can see the acetabulum in here. This is the socket. The acetabulum is made up of the ilium and the ischium and part of the pubic bone, all coming together to form the acetabulum. There's the crest of the ilium. There again, you can feel that coming off of your pocket. That's your landmark for that. Okay. Yeah. Okay, there's the acetabulum, the socket, the pubic bone, the obturator foramen. I mentioned that already. That's where those are large openings in the hip bones to allow the passage of nerves and blood vessels, arteries and veins. The ischium. And here is what I've been looking for. This is called the greater sciatic notch. The greater sciatic notch is a passageway that allows a very large nerve, the largest nerve in our body, to go from the pelvic region down our leg, down behind our knee, down to our great toe. It's called the sciatic nerve. It's a source of a great deal of discomfort for older people because that nerve easily, gradually becomes inflamed over time through pressure and through constant use. People sit on their butts a lot, and that's putting pressure on the sciatic nerve. And over time, it causes a constant pain, which may show up in their hip, in their knee, in their foot, because the nerve is very large. At this point, coming out of the greater sciatic notch, that nerve is about the size of your thumb. And this is the main reason why when you get injections, you don't get injections into your butt, because there's a very good possibility you may stick the needle right into the greater sciatic nerve. You don't give them into the gluteus maximus. You don't give injections into the gluteus maximus. You inject into the gluteus medius, slightly off to the side. In fact, you line up the gluteus medius based on the presence of the iliac crest. So let me go back here one. I want to show you. Let's take a look at, just to give you the whole perspective here. If we look carefully, let me go back one more. Yes, our sciatic notch is right up in here. Our greater sciatic notch is here and here to allow the passage of these large nerves to go down to our knee and to our great toe. That's where it ends. And the size of that nerve when it's leaving the pelvic region is huge. Again, it's as big around as, because the sciatic notch is right here and right over here. It's easily as big as your thumb when it leaves. When it's going through here, it's easily the size of your thumb, the thickness of your thumb. Okay, so there's your greater sciatic notch right there. And you really don't want to stick a large needle into your patient's sciatic nerve, because it's going to be a whole new experience and pain for them. So that's why whenever you get an injection in your gluteus maximus, it's always off to the side. Greater sciatic notch. And there's the lesser sciatic notch, because there's a second branch that forms the sciatic nerve. So you have two targets here you could work on. So, okay, moving down into the legs. Largest bone in our body is called the femur. You're looking at the femur right here. It is the bone of our thigh, or our thigh bone. Very distinctive in shape. No other bone looks like this. There's the head of the femur. Remember, the head's always on the medial side. So everything on the same side as the head is on the medial side. There's the neck of the femur right there. There is the greater trochanter. We had a greater tubercle in the humerus. Now we have a greater trochanter here. And if we have a greater, we got to have a lesser. And so we'll have a lesser trochanter on the other side. And there's our lesser trochanter right there. These are points of attachment for muscles. And we have what's known as the intertrochanteric line. When we flip it over, we'll see the intertrochanteric crest. So at the distal end, at the far end of the femur, we see the medial epicondyle. It's on the same side as the head. So it's the medial epicondyle. And that means that down here, we have to have the lateral epicondyle. Because if you got a medial, you got to have a lateral. Close up of both ends of our femur. Now we're looking at it from the posterior surface. There's the distal end, that's by your knee, and the proximal end's by your hip. There's our head. There's the greater trochanter. There's the lesser trochanter. The lesser trochanter is on the same side as the head is. Just like the greater tubercle was on the lateral side, and the lesser tubercle was on the medial side. And this is the intertrochanteric crest. Now this neck here of the, there's the head, the neck is right there. The neck is where, when someone is told that they've broken their hip, the bone that is usually broken when someone breaks their hip is the neck of the femur. It's not the pubic bone or the ilium or the ischium. It's usually the neck of the femur right here. So this is the most susceptible area to a fracture, is right across the neck. Okay, so moving down to the far end, we have the medial condyle. Now we have a condyle. We have a bump that goes up and down. We have the medial condyle, and that means that we have to have a lateral condyle. And that means that the bone that bulges out beside this is the medial epicondyle, and the bone that goes out that way is the lateral epicondyle. But these two large processes on the end of the femur are called the medial and lateral condyles because they go up and down. Okay. And there's the intercondylar fossa. I don't think I've ever asked that question. I'll just tell you that. So, okay. Now, at the end of the femur, we have the, we terminate with the knee joint. We have the medial and lateral condyles and epicondyles. We have the patella, which is our knee. And then directly below that, we have what's known as the fibula and the tibia. Now, the fibula is the most useless bone in our body. It's not load-bearing. It doesn't do anything. It doesn't support anything. It just gets fractured. It breaks. It's a very common skiing injury. The fibula breaks. It's sort of sitting out there all by itself. It's not load-bearing. It doesn't have a lot of support from any ligaments and tendons. It doesn't help us turn our leg in any way, shape, or form. All the fibula does is form the outside of our ankle. That's all. It forms the outside of our ankle. Because we don't have an ankle bone. But it is the most useless bone in our bodies. Anyway, the tibia, on the other hand, is the bone of the lower leg that does all the work for us. Now, there's our medial and lateral condyles, these bulges here that go up and down, and then the epicondyles go out to the medial and lateral sides. Okay, now what else? Now, okay, here's our fibula. Long, skinny bone with a head and what's known as a lateral malleolus. And I'll tell you that if this bone is out by itself, laying on a table for examination, you would be hard pressed to be able to tell the head from the lateral malleolus. When it's attached to the skeleton, it's different. The lateral malleolus makes up the outside of our, what we call the ankle, even though there is no ankle bone. The bulge on the, if you put your hand on at your foot and feel the bulge on the outside of your foot at the ankle, you're rubbing your lateral malleolus. That's the end of the fibula. And one of the reasons why I always use multiple choice now or use a word bank for this is because I used to get, when people would write the answers down, I would get fibia and tibula. I knew what they meant, even though they spelled it wrong. It's a whole lot easier if I give you a word bank or you have a multiple choice event. So anyway, because then you don't have to worry about spelling. And I never took off for spelling, but I know some people did. So, okay. Yeah. Let's take a look at this large bone of the lower leg called the tibia. First of all, there's a very prominent feature that you can find on your tibia. If you rub your hand down across the tibia, you'll feel about halfway down in the middle, along the medial surface of it, you'll feel a very sharp edge. That's called the anterior crest of the tibia. It's also what we call our shin bone. It's the one that we use to discover sharp objects with in the house late at night, like tables and chairs and stuff that shouldn't have been there. They got moved around during the night. The anterior crest is the sharp edge of the tibia. So, it's a very prominent landmark. when we look at muscles, next we'll use the anterior crest as a landmark to see where certain muscles are located. There's the anterior crest. Of course, you can see the fibula next to it on the lateral side. Here, there's the fibula out there. This is the head of the fibula here and here, but the fibula is always on the lateral surface. The big toe lines up on the medial side, always. So you have a medial malleolus lined up with the big toe, which is lined up with the medial condyle and the medial epicondyles and the head of the femur, always. So close up of our tibia. There is the medial malleolus. This is the other side of the ankle. If you put your hand down on the inside of your leg and rub your ankle, you are rubbing the medial malleolus. That is the bulge on the inside of your ankle, inside of your foot. That's the medial malleolus. They're not connected. The lateral and medial malleolus are not connected. It's like two bones that are coming down on either side of your foot. But the medial malleolus is doing the bulk of the work. So there's the medial condyle on the tibia, and there's a lateral condyle right there. And this is the anterior crest, the sharp edge across the front of the tibia that we often refer to as our shin bone, as I said. There's a tibial tuberosity. You will see that's where your patella, the patellar ligament attaches to the tibial tuberosity. We'll see that next week when we look at joints and articulations. And of course, there's the intercondylar eminence, because these are the medial and lateral condyles there. Now, okay. Now, the tibia and fibula to form our ankle come down on either side of this particular bone. Out of the way. The tibia and the fibula is coming down here. The tibia is over here. So this is going to be the fibula and the tibia. Here you're going to have the lateral malleolus here and the medial malleolus here to fit on either side of that large bone in your foot. So let me get rid of all that. Okay, so we have the right foot. Here's the big toe down here. The big toe is always on the medial side. Okay. There are the phalanges. These are the metatarsals, because bones of the foot are called the tarsal bones. These are the metatarsals. Now the remaining bones of the foot, 3 of them have the same name. One is called the medial cuneiform, lines up right behind the big toe. One is called the intermediate cuneiform, right behind number 2. And then number 3 is the lateral cuneiform. So medial, intermediate, and lateral cuneiforms. You've also got the navicular right behind all 3 of the cuneiforms. And you have the cuboid behind the metatarsals 4 and 5. But more importantly, you've got the talus here and the calcaneus back here. The heel bone is called the calcaneus. So the bone that you can feel at the back of your very back of your foot, that's called the calcaneus. The talus is the one you can't feel. The talus is the one that's surrounded on either side by the medial and lateral malleolus of the tibia and the fibula. So here we see, here is our tibia. Here, this is the medial malleolus right here. The talus bone is hidden. Talus bone is actually The talus bone is actually going, oops, wrong pen. It's actually underneath here. And so this is the medial malleolus here. And this over here is the end of the fibula there, with the lateral malleolus on the other side. So let's take a look at what these structures are. Okay, first of all, the medial cuneiform right behind the big toe. There's the tibia. There's the medial malleolus. There's the talus. You can't see the rest of the talus because it's hidden by the medial malleolus on this side and by the lateral malleolus on the other side. There's the calcaneus. Now, this large bone is where our Achilles tendon attaches to. Our Achilles tendon is, you can feel your Achilles tendon if you rub your hand down behind your calf muscle. It's actually called the gastrocnemius, but behind your calf, all the way at the end of it, you can feel your Achilles tendon as it's getting ready to insert or attach to the calcaneus. There's the cuboid, and then this was metatarsal number 1 here, and this is phalange number 1. So let me add a few things to this. Metatarsal number 1, phalange number 1. This was the navicular here. This is the intermediate cuneiform sticking up here, and you can't see the lateral. But the thing to remember is that this is the medial malleolus and the lateral malleolus set on top, or set around each side of the talus. They're not connected to it directly. They're held in place by ligaments and tendons. That's all. There is no ankle bone per se. The ankle structure is made up of the medial malleolus, the talus, and the lateral malleolus. So, and let's get out of this. And that should be, that's everything. Okay, that's everything in the appendicular skeleton. Let me get out of it and ask, does anybody have any questions? Okay, we've got one more week to go on the bones, and next week we will take a look at the joints and articulations, the movement of these various joints, and how, excuse me, and how the bones articulate with each other. And then after we come back from spring break, we will have our bone test online. And like I said, I'll probably give you a week to open. I'll leave it open for a week for you. So anyway, have any questions on that? Okay, then I'm going to get us out of here. And I will see you all in lecture on Wednesday.